Welcome back to the 260. Today we are joined by Zach Stoppenhagen, paramedic, nurse, and one of many voices for eCPR at Parkview Regional Medical Center. He will be breaking down what eCPR really is, how it works, and why it is changing the game of cardiac arrest patients, especially those who have the best shot of survival when time is everything. Let's dive in.
But we actually won the photo competition last year.
I saw that.
Yeah, so you can submit everybody submits their pond photos, and then whoever gets the most likes on Facebook gets a $300 off coupon for the next year's service. And so we won that and got $300 off, and then they decided not to use their services. So it was still going to be about $700. And I was like, looking at the chemical cost and it's looking pretty good. I think I can manage it myself. And so
yeah,
they said they'd still bail me out if I need it later in the summer. They'd still come and start the treatment, but it's not prorated based on the time. You're still paying the full amount. So it's okay, that's my backup plan.
I'm gonna have Pond Chance come in. All right, so let's get into this. So Zach, can you tell us a little bit about yourself? How did you get started in EMS? Kind of how that progression between being a paramedic, and then you went back and got your nursing, and you're also a flight medic.
Yeah, so I got started in EMS in 2005 or so. My dad was a paramedic for a long time, and I think I kind of followed in his footsteps. I tried going to school for business, and that was not my thing very clearly. So yeah, did my EMT, basic, advanced, and paramedic all down at Adams County, and graduated in 2007. And so shortly after graduation, I got deployed. I was with the Army National Guard and went and spent a year in Iraq, and came back, worked for Wells County EMS, and then for a couple of years, and then started with Parkview Samaritan for their mobile ICU when they very first started at Randalia. Worked for them for about 3.5 years, and then moved over to Lutheran and started working for Lutheran Air. And I was there for 9 years as a flight medic and supervisor and manager there. And then came back as a nurse then to Parkview, and I've been at Parkview for about 4 years now in the ER. So yeah, doing ER nursing now, and still work part-time for Adams EMS and Adams ER where I live.
Substantial experience.
Yeah.
I've been around both systems, both great healthcare systems in Fort Wayne, and so yeah, but I'm in a good spot now. I like ER nursing a lot, so it's good.
Do you happen to work with Mr. Newhouse at all?
Grant? Yeah. Yes, I do.
Okay, yeah, he was on the podcast.
Oh, was he?
Yeah,
okay.
Yeah. He came in and just talked about the nursing perspective in general and kind of what we can be doing to all be on the same page more effectively, I would say. And it was great. It was a good conversation.
Yeah, I bet it was. Yeah, Grant's a good guy. Got a lot of good experience. And yeah, I think too, the more we can integrate perspectives, the ER nursing standpoint and the EMS, bring those two together, the better. I've often thought that when ER nurses go through orientation, I wish they could do a ride-along on EMS to see what that's like.
Be helpful, I think.
I think it would be too. I think sometimes we need a little perspective as to what the EMS providers went through prior to coming to the ER.
And I think we get, as paramedics at least, and even EMTs in advance to a degree, you get that exposure of what it's like and then in the ER, but I think we quickly forget, hey, these individuals are juggling many different patients and a lot of different things that you don't really have to deal with. You don't have a schema for what that's like. And I think it would be good to remember, to remind, good words are hard, but to be reminded of what that's like.
I really like what you said, perspective. We need perspective on the different types of healthcare and how they work. And that's one thing that we do with the podcast is we get you on and we talk about what can we do to make your life easier and how can you make our lives easier and how can we bridge those gaps of, misinformation and stuff.
Yeah, absolutely.
Yeah, and so we have you on to talk about eCPR and how we can use it, what is it, and
I guess first of all, I'm definitely not an expert in ECMO or eCPR. It is something really interesting that we're doing here in the ER, and I'll talk about a little bit of what it is. But my background, like I became interested in it. I think when I was at Lutheran, we transported a couple of patients that were on ECMO from the ICU to like going down to Indianapolis. And so I've always been interested in critical care medicine, and that really interested me. And so last year when we started to integrate putting patients on ECMO down in the ER, I kind of gravitated towards that and became interested in it. Like, hey, what's going on here? What is this? What are we doing down here in the ER, So so I became interested in that. And then from the ER perspective, kind of became a little bit of a representative from the ER and started joining in on the meetings with the ECMO team and how is this going to work in the ER and what can we do to help better facilitate this process as staff nurses and, learn more about it to understand what we need to do to be ready for it as ER nurses. So, but yeah, basically what it is that we're talking about is eCPR is extracorporeal cardiopulmonary resuscitation. So it's taking a patient that is in cardiac arrest and placing them while they're in cardiac arrest and compressions are going on an ECMO circuit. And an ECMO circuit, if people are not familiar with what ECMO is, it's extracorporeal membrane oxygenation. So it is where you cannulate large vessels in the patient's body. Typically in an emergent situation, it's in the femoral vein or artery. There's a couple different kinds of ECMO. You can cannulate 2 veins and run that through the external circuit, or you can cannulate a vein and an artery. There's 2 different kinds of ECMO. The difference between the two would be in VV ECMO or venous ECMO is when somebody has adequate cardiac function. That comes into play more so in the ICU setting. If it really got popularized and used quite a bit during COVID when you had very, very bad lungs with COVID and patients were not able to adequately oxygenate, very high oxygen requirements and nitric oxide trials and everything else just wasn't working. Sometimes it would take and place that patient, cannulate them, and then circulate their venous blood through an external oxygenation circuit that has a centrifugal pump and a membrane to oxygenate their blood and then remove carbon dioxide and then place it back into the system. And so meanwhile, you can somewhat rest the lungs and gently ventilate those. And so that's when it would be used primarily for like VV ECMO. In this case, what we're talking about with eCPR is VA ECMO because the heart's not beating. And we cannulate one femoral vein and one femoral artery and drain the blood from the venous system and then run that through the circuit. So again, we're oxygenating it and removing carbon dioxide and then returning it to the arterial system. And effectively, it's very similar to placing a patient like in the OR who's on cardiac bypass. It's very similar to that.
What studies, what made you guys switch to this?
Yeah, so there has been a lot more studies with eCPR specifically over the last 5 to 10 years, looking at it and taking, like I said, initially ECMO was just used primarily in the ICUs. It was used in the ORs to put somebody on bypass while they were doing heart surgeries or lung surgeries. And then, not sure where the idea came from, but somebody somewhere along the way thought about placing a patient whose heart wasn't beating at all in more of an emergent situation like what we deal with on an ECMO circuit. So we've been doing it for, I think, about 1.5 years now at Parkview. They've had a lot of success with it up in Minnesota. Some of their systems up there have been using it, and there's been some pretty decent studies out there that look at eCPR and placing these patients that have been, have CPR in progress and have a potentially underlying reversible cause on this ECMO circuit, and it allows time for us to oxygenate the brain, oxygenate the other vital organs while we potentially treat the underlying cause. So that could be like a massive pulmonary embolism. It could be a clogged coronary artery, and we take them to the cath lab and place a stent, re-oxygenate the heart muscle. It could be an overdose that needs to be treated. So those are some of the situations where we can use it now, and they've had some good success with that. And we've had some success with it at Parkview too. So unfortunately, it depends on which study you look at. Sometimes it's, they take however many patients in the study, and it could be, they look at the success being a maintained, improved neurological outcome, up to 1 year, right? So the patient's walking out of the hospital and they're able to resume a functional life after being in cardiac arrest at one point, where traditional CPR wasn't successful. And so we're still collecting data on success rates, but we've had some success with it within our system.
That's awesome.
Yeah.
I was going to ask, how long can you keep someone on this? And are there any repercussions of what that might entail for them that are negative? Or is it really all just kind of pointing towards, this could be it, this is a really good thing?
Yeah, I think it's definitely not an indefinite thing. So up to, maybe 24 hours is when you're going to look at whether you're seeing improvement in the patient or not, or whether those underlying causes are potentially treatable and we're going to have success with that or not. So it's always hard to tell, and every patient case is different. Mm-hmm. Some patients you're able to get return of spontaneous circulation, and then due to their potentially prolonged downtime, it's one of those things where you just don't know how they're going to do until you start to wean the sedation and wean the ventilator and see. And then there's, of course, so many other potentially secondary complications that can occur from a significant event like that happen days later down in the ICU. That's where we look at patients that not only, it's one thing if we place a patient on ECMO and we are able to get return spontaneous circulation a day or two later, but we want to see sustained improved neurological outcome, long term. How long can they stay on ECMO? I'm not exactly sure if there's a specific time frame where they just have to cut it off. I'm sure each case is a little bit different. And that's ultimately up to the intensivist pulmonologist and the cardiovascular surgeon that deals with that patient up in the ICUs.
I guess that makes sense. People can be on it for a variety of different reasons, potentially. So
Right.
You can't put a blanket. We stop at this hour no matter what.
Yeah, exactly. And personal experience-wise, I haven't followed. We do get together monthly, and I try to attend the meetings through the hospital and they debrief each case that we have. And each eCPR case, we go through it and talk about what their outcome ultimately was. But I don't always follow them closely in the ICU setting. So
it kind of brings us to your protocol for it.
Yeah, and ultimately the decision of a patient, whether or not they get placed on eCPR or the ECMO circuit in the emergency department, is going to be a call made by the attending physician in the ER in communication with the ECMO team. So they'll be talking to a CV surgeon or a intensivist to make a determine if this is a potential candidate. But as far as the EMS standpoint goes, and this is where the protocol comes into place here. So Dr. Sowers, the medical director for Parkview EMS, wrote a protocol for Northeast Indiana Regional Protocols, and I think this has already been put out. But there is inclusion and a longer list of exclusion criteria that the paramedics or pre-hospital providers are going to have to look at on these cases. So I think, if I'm not mistaken, your protocol now for a cardiac arrest is to work them on scene for 25 minutes, is it? Mm-hmm. Yeah, so 25 minutes following ACLS protocols, and then if you don't get anything back, you're basically calling into med control for permission to cease. Is that correct?
Yeah, that's
depends on the rhythm, kind of.
Yeah, so right in the situation, if you feel like you need to work it longer or transport for some reason, right? So where this would come into play is the inclusion criteria for a potential ECMO eCPR candidate is, number one, we don't do pediatric ECMO. It's not a pediatric ECMO center. It's an adult ECMO center at Parkview Regional. So the patients are 18 to 70 years old. So that's your age range. They would potentially consider an adult-sized pediatric patient. if that makes sense.
Yeah.
For inclusion criteria. It has to be a witness cardiac arrest with the downtime less than 5 minutes prior to initiation of CPR. So these are witness cardiac arrests where CPR was started fairly quickly. And initial rhythm, we would like to see like a shockable rhythm. So it would be the initial rhythm. And then they would consider, we have placed patients on eCPR where their initial rhythm was PEA if there is a known potential reversible cause for that. Something we think we could get them out of. End-tidal CO2 greater than 10 once you are able to get a reading on that. And then a total downtime prior to hospital arrival will be less than 30 minutes.
Can you go back to the ETCO2? What'd you say one more time?
Greater than 10.
Greater than 10. Okay. I
Right.
thought that's what you said. Okay.
Yeah.
The thing less than that, they've been gone for a while.
Yeah.
Right. And so that's your general inclusion criteria that you're going to be looking for. So it's definitely a change of mindset. I picture it as the patient that arrests in the back of the ambulance or the patient that was a witnessed arrest on the factory floor, right? They saw him go down, they started CPR, they grabbed the AED. All those things happen very quickly. And it could be in somebody's home also. An arrest where somebody saw it happen and they started CPR fairly quickly.
This is really good information. Sorry to interrupt you, but I like what you're saying. And I'm trying to think about this from a perspective of a listener who maybe isn't involved in EMS, but they're out and about in the community. And so it's like, hey, if you know CPR, like, you could make a serious difference in someone's life, not just by doing CPR to them, but maybe putting them in the best case scenario to receive this potentially life-saving treatment at the hospital.
Yeah, absolutely. That's highly important to get the community involved in where the closest AED is or just how to initially start. As we know, compressions are the most important. So just start pushing on their chests hard and fast until somebody else gets there. So that's your general inclusion criteria. And these are the patients that we as EMS providers need to be triggering in our minds. Okay, this could be different. This could be a patient that we don't stay and work that ACLS protocol for 25 minutes on scene. This patient may be worth transporting to the hospital directly with high quality CPR in progress, whether that's via a Lucas device or people, either way. There is, like I said, a pretty decently long list of exclusion criteria. So obviously the first one's going to be a DNR order. That's pretty obvious, but it's in the regional protocol, right? It's got to be in there. You want to see if they have a BMI greater than 50. That is part of the exclusion criteria. And any respiratory arrest thought to be secondary to drugs. So that's in the exclusion criteria due to the high potential for an anoxic brain injury. Also, any other patient that has existing comorbidities. So a patient that's got COPD that's on oxygen chronically, a dialysis-dependent patient, a patient that has heart failure diagnosed with CHF, a patient that does dialysis, somebody with a history of neurological impairment.
Any of these comorbidities are
Any of these big comorbidities would be exclusion criteria.
Yeah. And it kind of makes you think of, we've all had those cardiac arrests where you're like, man, like if the right things were in place, this person would live because they're so young and they just happen to have like that one episode or that clot that just happened to break off and include or plaque. And I love this for those patients because it gives them that fighting chance. The reason why we're like, they just happen to have the unlucky straw of having a cardiac event today. And this can really help them.
Yeah, you're exactly right. I think that's the target population that we're going for. And just, I do think it will be very few of the cardiac arrests that we get called out to that are going to ultimately get placed on this ECMO eCPR protocol. But that's the goal. It's the patients that shouldn't have passed away, that there is a reversible cause, like you said, that we can get in quick and everything, all the stars aligned, and we get them to the hospital and we can get them cannulated. That's one of the biggest, or perhaps the biggest factor in the success or failure of eCPR and improved neurological or sustained neurological outcomes long-term is the amount of time that the patient was in cardiac, or the amount of time that compressions were being done prior to the patient placed on a ECMO circuit. So the most value that this has is the patients that are close to the hospital that had compressions going for ideally less than 10 or 20 minutes, 10, 20, 30 minutes by the time we are able to cannulate them. So, but we have seen success on patients where CPR has been in progress for up to 60 minutes in the ER, and they were cannulated, and the patient had a reversible cause, and they ended up walking out of the hospital. And
that's the goal.
And
Yeah.
that's a patient that we would have otherwise done CPR for a certain amount of time. We try everything in the resuscitation bay that we know, and then eventually you're going to cease resuscitation efforts, right? Because you've used up everything you have.
How frequently is someone on ECMO at the hospital?
I don't know the answer to that as far as in the ICU, how many patients they have on at a time. They may have 1 to 2 patients on it at a time in the ICUs up there, but how often we're doing it in the ER and these eCPR, like I said, we've been doing it for about a year and a half. And I think I would have to ask Sean Hart, she's our ECMO coordinator, but it seems like 1 to maybe 2 per month so far.
Okay.
Over the past year, they've really been working on developing the team and refining it. They've been doing a lot of simulations to where they'll call an ECMO activate, and the team will respond, and they have a mannequin that we'll have in the emergency department in the bay, and we'll have CPR in progress, just like you guys do realistic training. We do realistic training there to where we actually have compressors compressing the mannequin.
That's cool.
The ECMO team arrives with a perfusionist, and the perfusionist is the person who operates the ECMO circuit, the flow, and the oxygenation, as well as a cardiovascular surgeon and other ancillary members of the ECMO team. So you have ECMO support nurses and coordinators, and they've got a big group of them that respond. So those have been really interesting to watch. We stopwatch and track their time on how soon they can get to the ER, and then how soon we can get that patient cannulated. So they've really worked on improving, and I'm not going to say perfecting because it'll never be perfect, but really developing this protocol over the past year and a half to where we can use it in the ER. Then now we can actually put it out to EMS to where we have 24/7 support of this team. Because ultimately we can get, they always have a circuit prepared and ready on standby. That's an emergency circuit that is primed and ready to go. So they just need to bring that down to the emergency department. The one thing that is another thing that is a potential holdup is a physician to cannulate the patient. So we're also getting more of our emergency room doctors through the training to where they can actually cannulate. Yeah, as of right now, it's either going to be a cardiovascular surgeon or a ICU intensivist pulmonologist or one of our emergency department physicians that will be cannulating. So, but they do have a protocol in place to use this 24 hours a day.
So what would you say for anyone that wants to start a program like this? Like, what advice would you give them?
I guess for me, like a lot of things in EMS or the hospital, there's enough programs out there doing it that there's no reason to reinvent the wheel. I was not part of getting this program started in the ER whatsoever. I just kind of jumped in at the tail end because I'm super interested in it and I think it's really cool, in the ER, and I'm excited about it, especially from the EMS standpoint, potentially seeing these patients that otherwise would have not made it. It's like, hey, there might be another option for this 40-year-old who had a heart attack and, it was a witnessed arrest and we can potentially do something about it. So that's my interest in it. But yeah, otherwise, I know there are other major centers across the country doing this. So whether it's from a EMS standpoint or a in-hospital standpoint, I guess if you were going to start a program, I'd say link up with one of those folks that have been doing it for a while and see how things are going.
We can reach out to you guys, right, and request training for departments that are very interested in what Parkview is doing right now here in Indiana. you can reach out. I'll put it in the show notes. And you also had a PowerPoint, and I will put that in there.
Yeah, that sounds good. Well, I'll make sure and get you the PowerPoint, and then that also has, and we can include Sean Hart's email address. She's our ECMO coordinator for Parkview Hospital, and you can feel free to reach out, email her, and then we can set some training up with you guys as we roll this protocol out. So I think the next regional providers meeting is in May, so it'll probably be addressed then again as well. As it relates to the medical profession, I tend to listen to podcasts that aren't medical a lot of times. One medical podcast I really do like is Pharmacy to Dose. It's a emergency critical care pharmacist out of Indianapolis, and he does a great podcast, brings other pharmacists and clinicians on that talk about emergency medicine. And it's something I felt like from a paramedic standpoint, you always want to know like a little bit more about vasopressors or, just that stuff that you kind of have a surface knowledge of, but you really would like to dive into more and maybe get a refresher.
They gave you the quick and dirty in paramedic school.
Yeah. Like, what receptor did that act on again? Yeah. And what's the difference between these two and how do I titrate them? And so, that's really good. Pharmacy to Dose is a good one. And as far as books go, I read a lot of old history books, but my go-to, I'm just going to have to default and say the Bible's going to be the biggest impact I can recommend. If you don't read it, you should. So,
yeah. If you could have anyone on our podcast, like just anyone out there in the community, who would you put on here?
Ooh. Oh, boy, that's a tough one. I'd like to see Dr. Gutwein and Dr. Sowers on here.
Okay.
So I don't know
Go
if you
about the same time?
They're related.
Oh, they are? I did not know that.
Dr. Sowers is Dr. Gutwein's daughter.
Oh, that would be so awesome.
Yeah. From the public health, the emergency medicine, the EMS, just a world of experience between the two of them. And I think that would be great off the top of my head.
Oh, that would be hilarious. We need to hit them up.
Yeah. That's who I'd recommend.
Have like a father-daughter battle of the wits,
yeah,
right?
Exactly.
That'd be so much fun.
You could probably make it pretty interesting.
Yeah. Well, Zach, we love having you on. Thank you for coming in and giving us some very wonderful insight on eCPR. As you guys know, leave it better than you found it.